So hello, I am Donna Setzer, Co-Executive Director of the Southeastern National TB Center. Welcome to today's webinar titled When TB is the Least of Their Worries, Drug Interactions. We are so excited to be hosting our 9th webinar in this series. If you missed any of the previous 8 webinars, you can find them all on our website. We missed all of you in 2020 and are happy to have so many of you here with us today. Today's speaker is Melissa Badowski. Dr. Badowski is a clinical associate professor in the section of infectious diseases pharmacotherapy for the University of Illinois at Chicago, College of Pharmacy. Dr. Badowski manages patients with HIV in the Illinois Department of Corrections through telemedicine services. In addition, she manages various infectious diseases, including TB and latent tuberculosis infection, through an interdisciplinary practice at the University of Illinois Hospital's Family Center for Infectious Diseases. Today's moderator is Connie Haley. Dr. Haley is a medical consultant for the Southeastern National TB Center at the University of Florida. She is also an adjunct clinical professor in the Department of Medicine, Division of Infectious Diseases and Global Medicine at the University of Florida. Dr. Haley provides expert consultation to help other healthcare providers care for challenging patients with TB disease and LTBI. She also conducts training and education to build capacity among public health programs, community providers, and healthcare facilities to manage patients and prevent TB transmission. And now I'll turn it over to Dr. Connie Haley.
Good morning. Thank you so much, Donna. It's good morning, good afternoon, maybe even good evening. I'm so glad that we are finally getting back up to speed and having a 9th webinar. That's kind of hard to imagine, but very exciting. And I'm particularly excited that we're going to be working with Dr. Badowski. I first heard her speak a couple of years ago at a statewide meeting in Illinois. And as I heard her speak, I just knew that she was someone that we really needed to get to come speak to our audience in TB, beyond just Illinois, and try to share her expertise and enthusiasm for TB pharmacology. And so I'm so happy, Melissa, that you were willing to join us today. And with that, I'm going to let you begin your presentation.
Great. Thank you so much. And I appreciate the invitation to do this. I just want to make sure that my screen is sharing appropriately.
It looks great.
Okay, fantastic. Again, thank you for all of you being here. Good morning, good afternoon, or good evening, wherever you may be. Just some of the thoughts behind really wanting to look at drug interactions, especially with TB medications. As a pharmacist, I get asked these questions on a daily basis. And sometimes I have to be reactive in my approach in one of my clinical settings where somebody has already decided to put somebody on this therapy, and now I'm trying to play catch up and manage these drug interactions. And in some instances, I do get consulted and asked about it before somebody goes on TB therapy or TB treatment. So I know we said we have no disclosures. I do have one tiny disclosure, and that is that you cannot possibly remember every single drug-drug interaction that occurs with tuberculosis medications, not even me being a pharmacist. So my goal for you all is to be able to look at resources and identify these resources as to where you can look for TB management and how to manage these drug-drug interactions. So with that, our learning objectives are outlined for you. And really most important is to identify and manage common drug-drug interactions with anti-tuberculosis medications. And we really want to make sure that we are going to increase effectiveness. Yes, there are side effects that can occur, but we also want to make sure that we treat appropriately. And then finally, to learn 2 resources in being able to appropriately adjust TB medications. So in terms of drug-drug interactions, I think we're most familiar with anything that we see that is a drug and drug. But we also have to make sure that we think about drug-food interactions, supplements, because a lot of our patients may not think of supplements as being a medication or a drug. And then finally, we think of the medical condition, where I'm sure most of you are familiar with drug interactions with the nasal decongestant that is pseudoephedrine, and how that can elevate blood pressure. So we have our work cut out for us. We can't just always think of it's just a drug-drug interaction. But what we think about with these drug interactions that do occur is that they could reduce the efficacy of the medication. When we think of anti-infectives, we think about how they can potentially cause resistance. And we also think about how they can increase our side effect profile. So we may see increased toxicities. So when we couple all of these together, we think of how from causing adverse effects, increasing drug actions, as well as decreasing the drug action. But the other thing I want to think about is with food absorption and the drugs, it could reduce how well something is absorbed. So some medications have to be taken on an empty stomach. Some have to be taken with a full meal. And then the other part with the data lacking with supplements, we have to remember that most supplements aren't FDA approved. So the interactions and the studies that are done are sometimes theoretical in certain bases. So I think that's also something that we have to make sure that we're monitoring for our patients. In terms of drug-drug interactions, we all know that they can lead to hospitalization, and severe drug interactions can even lead to death. So what it is, my job as a pharmacist is making sure that we prevent this from happening. And, you know, some clinics have a pharmacist on staff and some do not. So I always encourage people to look up drug-drug interactions. And I was always taught that I should look at least 2 resources, because what I find in one resource may not necessarily be the same in another. But I think just making sure that we are doing our due diligence at every office visit, whether they're just stopping in to pick up medication, sometimes in my setting, or if they are on directly observed therapy, just asking, has anything changed with your medications? I recently had a patient come in on Friday while I was in clinic, and we were initiating antiretroviral therapy for this individual, and I asked, are you on any other medications? And they're like, no, not at all. And I'm like, well, do you take any supplements or multivitamins over the counter? And the patient said, oh yeah, I take a multivitamin. I actually take a prenatal multivitamin. I'm thinking of becoming pregnant. So that's something I need to know, because some of my medications can interact with that. But what I think is really important to see is that with 2 medications, your risk for a drug interaction is about 15%. But if you couple that and go up to 5 medications, it's about 40%. And when we see 7 medications or more, the risk is about 80%. So think about if we're starting TB therapy, and at a minimum, we're on 4 active drugs, with pyridoxine being a supplement that we have to have. So that's 5 medications right there. There's already a 40% risk of drug-drug interactions. Now, what if they're on a medication for a chronic disease state, on a couple of them? We see that elderly Americans are on a minimum of 5 medications, about half of them. Half of our population are on that many. And then about 12% are on 10 or more medications when we look at elderly Americans. So I know that there's going to be a drug-drug interaction that I have to be worried about with our populations that we serve. So bear with me while I go back to my pharmacy school days and learn all about cytochrome interactions. But these are really going to be our most common drug-drug interactions that we see. Yes, there are various other drug interactions with transporters that we may see that increase clearance. But what I really want to focus on here are the cytochrome enzymes. And so the names come from them being bound to membranes within a cell, so cyto, and then it contains a heme component. So that would be your chrome P, so cytochrome P. And then these are essential for various functions throughout your body, but most notorious are for cholesterol and steroid synthesis. They're not just in the liver, contrary to what we think, but when we think about drug interactions, most will go through our liver, and they're needed to break down our drugs or metabolize them. So within the body, a little trivia fact, there's about 58 of these that can be found, and that's what's been characterized in humans. So if you ever are asked that on a Jeopardy question, you will have the answer for all of that. So in terms of understanding our names, we commonly will see that cytochrome 3A4, where 3 is the enzyme family, A is a subfamily, and 4 is that isoenzyme. And so there are 5, just 5 little isoenzymes and cytochromes that are responsible for 90% of drug metabolism. And our most important one is going to be that cytochrome 3A4, and it is responsible for the majority of drug-drug interactions that we're concerned with. In terms of factors that can alter activity of the enzyme, there's the potential to increase the toxicity, and this is either by reducing a conversion to a non-toxic metabolite, or it can increase to toxic metabolites causing increased drug interactions. Or, as I had said before, it can lead to decreasing its therapeutic effectiveness. So it increases that rate of metabolism and how a drug is broken down. And so there are three potential actions that a cytochrome can produce. You may be familiar with the terms substrate, inhibitor, and inducer. And so when we think of our first action, a substrate is that drug or substance that is able to be metabolized by the enzyme. So when we couple this with an inhibitor, we start to see the drug levels going higher, and that could lead to toxicities. Or if we have an inducer, that's where we start to see a reduction. But when we talk about the substrate, going back to that, we see calcium channel blockers are notorious examples. Certain statins can be an example, or protease inhibitors within HIV therapy. So this is something that I have to be aware of when we're seeing our patients with comorbid disease states. When we discuss a cytochrome inhibitor, this is something that will decrease that enzyme activity. And so we start to see a reduction in the clearance, and we'll see an increase in the half-life of the substrate. So in particular, when we have a strong inhibitor, we can see a greater than 5-fold increase in plasma concentrations and more than an 80% decrease in clearance. So this is really important because this is where we start to see that toxicity, as I had said. So, when we look at various medications, they're broken down into strong, moderate, or weak inhibitors. And we'll talk about that a little bit more in an upcoming slide. And then we see inducers. So the good thing is inducing occurs less often than inhibition, but this is where I'm concerned with reducing therapeutic effectiveness. And so especially when we're treating TB, we think of the anti-infective. We don't want to promote any sort of resistance. This is where I get really concerned. And then also when we see co-infection with maybe HIV, where we can, again, promote viral resistance if the medications are being induced too quickly. And so what we tend to see is it occurs over time. So it could be 10 to 14 days. It doesn't have to be just within a few hours or a few days, but it can take up to 2 weeks before we see these inducing properties. And then we also have to make sure that we think about these de-induction properties. So, it could take 14 days to be seen, but then we also need to make sure that we see 14 days to discontinue. So when you see a medication and you have them on concomitant therapy, you want to make sure that you do wait those 14 days, kind of like that washout period. And so notorious inducers for me are NNRTIs, and although those aren't necessarily first-line antiretroviral agents nowadays, we still may be seeing that. A lot of the anti-seizure medications, and of course, rifamycins, which we'll talk extensively about today. And so a picture is worth 1,000 words, and everything I said could probably be summed up into this picture, but I like to see the words, and I like to see also kind of what goes on. But essentially, if you have that substrate and the inhibitor, it gets metabolized through your liver, and we'll start to see that substrate concentration increasing, and then therefore we see an increased toxicity. And then subsequently, with a substrate and inducer going through the liver, we see that concentration being reduced, and that's where I start to get concerned with the reduced efficacy of the medication. So in terms of metabolism of tuberculosis medications, I do not expect everyone to remember that 1A2 is a weak inducer of rifampin, but at least have this resource of where you could see some of these drug interactions occurring. I'd like to bring your attention all the way over to the right-hand side of the slide, where we see that CYP3A, 4, 5, and 7 enzymes, and really it's going to be that 3A4, where we start to see really that the rifampin, rifapentine, and rifabutine, all of those rifamycins having inducing properties. We see isoniazid being a weak inhibitor. And then some of the multi-drug resistant tuberculosis medications, we tend to see bedaquiline, protomanid being a substrate. But then also you see that rifabutine also acts as a substrate. So it has this two-way dual property for a rifamycin of how it can potentially interact with other medications. But these are the medications that will go through the cytochrome enzyme system. So just to be aware of these various properties that do occur.
Melissa, I love this table, and I'm going to, print it off and keep it handy because I think it'll help me quite a bit. One thing I notice is I do not see pyrazinamide or ethambutol on this table, and also just realized I don't see quinolones. Can you make a comment about that? And are these drugs we need to be looking up as well?
Absolutely. So quinolones, we'll talk about that a little bit later on in the presentation, but they are something that we are definitely concerned about. In terms of pyrazinamide and ethambutol, they don't go through the cytochrome metabolism or enzymes. So that's one of the things that we definitely won't see in that. They do have some drug interactions, but they're not ones that can't be monitored. So we think of pyrazinamide. I think of that really being with rifampin, and it can increase the risk for hepatotoxicity. So really monitoring the LFTs, which we would do anyway throughout TB therapy. And then ethambutol, the same thing. Not many drug interactions, which is nice, but it can interact potentially with aluminum hydroxide, which could reduce how effective it is. So we'll talk about those a little bit later in the presentation, but these are not ones that I have to worry about as much as I do with our rifamycins as well. So keeping on that train of thought of rifampin interactions, there was a review that was done, I believe it was in 2019, and it evaluated rifampin interactions based off of therapeutic areas. And so what I'd like to draw your attention to is really the most offenders that they had found in their review was that oncology agents, which they interact with just about everything. That's another drug-drug interaction that I would constantly look up because oncology medications are changing very rapidly and coming to market very rapidly. But then also we need to think of cardiovascular and anti-infective medications. So that makes up a huge majority of the drug-drug interactions that we see. But we also have to be careful with some of the other medications, antiretrovirals, CNS medications, and so you can see how it's broken down a little bit further. But again, I want to draw your attention into the HIV and AIDS treatment. Although if you look at this slide, it was only about 6% of drug interactions. This is something we need to think about because in terms of people who have tuberculosis, they're 20 times more likely to be infected with HIV as well. So that's why we really need to make sure that we're seeing a lot of these and paying attention to these drug-drug interactions. So when this study was done, NNRTIs and protease inhibitors accounted for the majority of the drug-drug interactions that we see. But the integrase inhibitors were something that were about 15%. And I think if we looked at this study now and reevaluated some of the literature that's out there, I think you'll start to see that the integrases take over a majority because these are the medications that are recommended as first-line treatment for HIV paired with nucleoside reverse transcriptase inhibitors. So NNRTIs and protease inhibitors are reserved for certain situations. They're not necessarily initiated in individuals anymore, whereas those integrase inhibitors are at this point. And then we think of other anti-infectives. So with antibiotics, you'll see that Linaselid is on here, but these interactions, they're reported, based off of the theoretical or potential interactions. But what we also have to make sure is that we are doing a balance of what we can and cannot use. If it says that it's a drug interaction, and we'll get into it a little bit later, there are absolutes that I would probably never use, but then there's some that I would consider using as long as I'm managing the drug interaction. So, yes, these interactions occur, but it's about being able to identify and manage them. When we think about antivirals, so specifically with some of the hepatitis C medications, valpattosvir, cimeprevir, and grazoprevir, these can interact at a significant level with rifampin. So the nice thing is with a lot of our hepatitis C treatment nowadays, we have a limited course where it could be 8 to 12 weeks of therapy, as opposed to when it used to be much, much longer, and cure rates weren't very high. But these medications are pretty costly. So we want to make sure that we don't necessarily use rifampin or some of these rifamycins that can reduce the efficacy. If we could hold off maybe on latent TB therapy, we would hold off until we've completed our course for hepatitis C therapy. So I think, doing that risk benefit is definitely needed. And we don't want to preclude the patient from achieving a cure for hepatitis C therapy. And then we also see antifungals. And again, maybe we can use rifabutin as an option here with fluconazole. But again, our rifabutin dosing would have to be reduced. So, again, it's not contraindications, absolutely never use, but making sure that we're able to monitor patients as well as manage the drug interactions. And so this will bring us to our first audience response question. And so we'll have you vote on this. What seizure medication or medications has the potential of interacting with isoniazid? Is it carbamazepine, phenytoin, oxcarbazepine, or all of the above? So please indicate your answer on the screen.
Melissa, this is so great so far. And in particular, I appreciate you pronouncing those words because those are ones I always have a hard time with. Donna, I am not seeing the response to the question.
Okay, well, we have about 47% responding. A majority of them are saying all of the above, a few with with number one, and about 20% are saying the second one, but an overwhelmingly 73% are saying all of the above.
Great. Melissa, what is the right answer here?
It would be, and I feel like as a test taker, you should always pick all of the above. But no, it is all of the above. And again, it's the can interact. Again, it's going to be based off of how you manage the drug interaction. So carbamazepine can increase your risk for induction is one of the major things that we think of with cytochrome. But then also it can increase your risk for hepatotoxicity. And that's a lot of the times because there's a hepatotoxic effect by accelerating metabolism of isoniazid. And so it can actually increase hepatotoxic metabolites. So that's where we start to see potential increase for LFTs here. Phenytoin is going to be paired with isoniazid, a weak inhibitor of the cytochrome enzyme. So specifically, this will be through inhibition of 2C19. So I'm not going to get into all of these when we look at the specific enzymes, but it will pop up on one of those drug interaction checkers. And then oxcarbazepine is supposed to have less drug-drug interactions with isoniazid. But again, it can increase your LFTs. There have been case reports where oxcarbazepine can be an inducer, but also act as a substrate with our isoniazid, even though it is something that can inhibit the cytochrome. So I think most of what I think about is monitoring of the LFTs for these individuals. And I think that's just across the board with all the seizure medications. Or even if we're potentially using like maybe valproic acid. I like to think that if we're using seizure medications, the safest one that I'm always taught is to use levetiracetam. Again, say that 5 times fast. But again, levetiracetam is going to be the safest option with a majority of major drug-drug interactions that we see.
So as a clinician, I'll put my patient on 4-drug therapy, and I'll be reviewing, or I want to do that, and I'll be reviewing, their medication list and looking at drug interactions. But sometimes, you can't avoid, if you really felt that INH needed to be included, I can always check drug levels of isoniazid to make sure those are correct. But which of these can you also check drug levels for to make sure that you're not getting into toxicity?
Yeah, that's a great question. You can actually check all of the levels for these. So these are commercially available. I don't always have the luxury of being able to use all the drug interaction or drug levels for some of the TB medications, but these are easily available. So we're able to definitely monitor these without a problem.
The thing that I really want to point out too is that, really in keeping with the theme of this series, TB is the least of their worries. In a patient with a seizure disorder, we could cure their TB. We certainly don't want to, cause a bigger problem where they have a seizure in a car accident or in some other scenario where it's hard. So you really want to coordinate the care of the TB program with the patient. And, we can pretty easily switch out isoniazid for another drug, and their guidelines in the current MDR TB treatment guidelines, it tells you how to manage patients who have INH resistance. Well, not being able to include a drug because of a drug-drug interaction, isoniazid is an easy switch, and you can use Levaquin or moxifloxacin in place and still manage to treat the patient in 6 months. And so this is where, if you have a patient who's got an underlying significant problem with drug interactions, it's really good to consult a pharmacist, consult either a TB expert if you aren't quite comfortable with that, and definitely include the patient's other providers in the management of the patient.
Yeah, I think that's a really important point, working collaboratively. If I'm managing somebody who is post-transplant, and we're worried about latent TB therapy, which, we'll kind of talk about in a little bit, I make sure that I get everybody on board. I send emails, I pick up the phone. I think all too much we neglect to think just the easy communication strategies, especially when I'm putting medications on board for a patient. If I have to think about if they can afford them or we're able to get them at a pharmacy, I just pick up the phone, hey, is this covered or not? So I just think having that collaborative piece, making sure that the patient is the center of this and making sure that we work collaboratively is of utmost importance.
Yeah, that's really important. And, again, your centers of excellence may be able to help get you in touch with pharmacists. We're certainly glad to do that. And I'm guessing Melissa will be glad to answer questions when we have them. But we also have Dr. Peliquin, who is a valued member of our team. Before we move on, because I think this is kind of the last we talked about isoniazid, are there any other drug interactions with isoniazid that you think the audience needs to pay attention to?
Yeah, I think of when we talk about itraconazole, if you're using it for certain antifungal properties, that's one that I would think about, and it can be induced by isoniazid, so we might need a little bit higher levels. We think of corticosteroids potentially can be affected. Again, these are potentially can be effective. What will happen to every patient is going to be patient specific. And then tacrolimus, I start to think about this as the potential for inhibition. So it's not an all-intensive list or inclusive list, but these are some of the ones that you may end up seeing.
Yeah, and the tacrolimus, I always called it tacrolimus, but that and the steroids, it's really important if it's a transplant patient, we really don't want them to become less immunosuppressed and have rejection, because again, that's a lot bigger problem. We can cure their TB, what we can't do is replace their transplant. And so
Absolutely.
Again, don't go it alone. Great.
Yep.
Well, thank you. Let's move on to the next part of your talk.
All right. Well, we're in a busy clinic today. We have all of our patients waiting. So let's get to our first patient who we're going to see. This was somebody that we had seen for a pre-transplant evaluation in our ID clinic. And it was a 27-year-old who had a history of IgA nephropathy. And unfortunately, they are on peritoneal dialysis. Patient came into clinic today. They're doing well. They don't have any constitutional symptoms of tuberculosis, so no fevers, chills, weight loss, or night sweats. But they did have a quantiferon that was positive. So a little bit of their social history. They immigrated to the U.S. about 5 years ago from Vietnam. Previous smoking history, but none currently. Alcohol, very limited, but previously they had a little bit more. And then they are living with their parents and a younger sister, and they work in a nail salon. So what I look at is their medications, so making sure that I have an all-inclusive list. And they're on atorvastatin, bumetanide, calcium acetate, carvedilol, hydralazine, losartan, minoxidil, a multivitamin for good measure, and nifedipine. So as you start to see, we have a patient who has pretty resistant hypertension as well. And I should say, when we had seen this patient, nifedipine was recently added on to their therapy because they were not controlled previously. So, that's another thing to consider. So quantiferon was positive, their chest x-ray was negative, and then blood pressure still not at goal and an elevated LDL. So we were going to initiate latent TB therapy in this individual. So this would not be a regular talk without any epidemiology talk. So I feel like we have to, make sure that we do address this. But I will say the good thing is that tuberculosis, latent TB, multi-drug resistant, as well as extensively drug resistant TB is reducing. And the good thing is so are deaths. And this is based off of the most recent data from 2019. And this data is typically coincides with being released with World TB Day, which is right around the corner. So I believe it's March 24th. And so right around the corner, which maybe there will be new updated statistics where I probably expect to see a reduction because, this would not be any talk without talking about COVID. And so with a lot of that's going on, I'm sure, hopefully that it went down even further. But in our own backyard in the United States, in 2019, there were about just under 9,000 cases of new TB diagnosis. But then what I start to think about is our latent TB infections. So, based off of most recent statistics, could be up to 13 million of the population. So a lot of people may not know their status, but, there certainly is a lot of individuals who have LTBI infection. And what we have to think about is that only 5 to 10% actively go on to developing TB, but in individuals who have immunosuppression, who are maybe on biologic medications, those are things we have to consider that can exacerbate their latent to turn into active TB infections. So I think that's something important that we need to make sure that we identify it and then treat it, and especially in this patient, because they are going to go on to have immunosuppression if they do receive a kidney transplant. In February of 2020, the latent TB infection guidelines had gotten updated. And so I think the biggest thing that we need to be aware of is that Isoniazid monotherapy is now an alternative therapy. So it's not one of our first line recommendations. And it was based off of a lot of toxicities or adverse effects to Isoniazid, to long-term therapy with Isoniazid, as well as not many people were completing 6 to 9 months of therapy. Again, it's really hard when somebody doesn't feel the effects of a disease state to make them have buy-in as to why they need to continue on therapy. So it was replaced with newer recommendations where a 3 to 4 months of therapy is going to be preferred, a much shorter duration. So we see that the strong recommendations are for Isoniazid plus Rifampin that's given once weekly for 3 months of therapy. And so that's a major recommendation, as well as once daily Rifampin for patients for 4 months. So again, strong recommendation. And so, something we see for HIV versus non-HIV infection, there isn't, there's not data for Rifampin necessarily, but again, what I tend to think about is from that drug interaction potential. And so Rifampin will interact with a lot of my medications. Rifampin, yes, it can interact with some of the medications, but again, it's about going of how we can manage these drug-drug interactions. So we'll talk a little bit about how they differ in the upcoming slides. This is a resource that I find very, very helpful as a pocket card as to remind what latent TB infection therapies we can use. And so this is put out by the CDC and in conjunction with the guidelines. And so these are national recommendations of where to use what medications. And so again, it's going to be really preferring the rifamycin-based therapy over INH monotherapy. And so again, it gives it a little bit of a better idea of how long we want to treat for, the frequency of treatment, the total dosing, as well as the dosage by adult versus children. So I'm sure you're looking at this and you're seeing that children have higher dosing compared to adults. And that's going to be because children metabolize the medications much more quickly, and therefore it's going to reduce our concentrations of the medication. So we have to have that higher milligram per kilogram dosing in order to make sure that we do have adequate concentrations for children, when we're treating latent TB infection. So we go back to our patient, and now I really want to focus in on the medications. We need to make sure that we're able to use a rifamycin-based therapy if we can. And so at all costs, we're going to make sure that there's not many interactions. I know that I can't really remove some of our antihypertensives because what's worse, that a patient's blood pressure will increase and I put them at risk for other cardiovascular events that could be fatal. So I need to do that pro-con, what's going to help the patient the most. So I use this as a drug interaction checker. There's various ones. I'm just using the one that my institution has that's accessible to us. And so what I see is when I put in some of the patient's medications or when I put in their medications, it lights up. So I have a lot of drug-drug interactions that I see. I see with rifampin, there's some contraindications with nifedipine where it can induce the nifedipine metabolism and reduce how effective it is. So I should be avoiding this combination. That's what our X will stand for. D classification is that I should consider therapy a modification. So rifampin, of course, can reduce how well atorvastatin can work. But then I see a lot of these C's where it says to monitor therapy. So what my take-home message here is that rifampin is going to cause me to have a little bit of anxiety. And anytime you see rifampin, it should say, hey, I need to stop and think. And maybe I need to just put these into a drug interaction checker. Honestly, I know it's a lot of our clinics are really busy, but it takes 30 seconds to put in all of these medications. Unfortunately, if a patient is 20 plus meds, which we tend to see, it might take a little bit longer, but I'd rather be safe than sorry. But I just know from here that I don't want to use rifampin. And that's because, it's going to cause a lot of those inducing properties. Now, I just do want to take a step back for 1 second before I move away from the slide. But we see that carvedilol can be reduced. We see losartan can be reduced. These levels are, something that I'm concerned with. And yes, I can monitor the patient. But when this patient has as many, again, medications that they're on for one condition, every medication essentially counts, especially if I'm maxed out their medication therapy. So one of the things I like to think about is that it's a nice day, and in Chicago today it's 60 degrees. I'm in my sports car with the roof down, and I start to have rifampin and any rifamycin for all intents and purposes. We start to see that there's a ramp up effect, meaning rifampin will reduce how well a lot of our substrates work in its presence. So, that's really something that's important to pay attention to, how effectively that it does reduce concentrations of medications. So that's really, rifampin is that moderate to potent inducer. And so not only will rifampin levels or rifampin reduce some of these medications through a cytochrome interaction, but it also is a P-glycoprotein, what we call multi-drug efflux transporter, which can reduce, again, medication. It reduces how well the medication is going to work. So it speeds up the clearance of a lot of these medications. So I want to make sure that I am paying attention to all these drug interactions that are ongoing for rifampin-based therapy, as well as rifamycins just in general. So the one thing that we see from this is that all rifamycins are not created equal. They do have little differences that I'd like to walk you through. So we see rifampin, its serum half-life is much shorter compared to rifabutin or rifapentine. And so what we tend to see is that it reaches a steady state much quicker, but then also that we can see probably quicker and more potent sterilization of our Mycobacterium infection. So that's really why it becomes that mainstay of therapy. But again, also we have the most data with rifampin in a lot of these studies. But there are indications as to why we would want to use rifapentine or rifabutin specifically, when we start to think about other drug-drug interactions that are going on. When we think about our effect on the cytochrome 3A enzyme, we again see rifampin causing the greatest effect, where rifabutin is a little bit weaker. So that means that I could get away with doing maybe having a little more room for drug-drug interaction potential, or what I'm saying is I could use this in place of rifampin in a lot of instances where I could at least manage these drug-drug interactions. It's not an absolute contraindication. The other thing I'd like to draw your attention to is that there's this auto-induction. Where we see this with rifampin, we also see it with rifabutin. And so this is going to allow for these medications to really induce their own properties. We don't see this with rifapentine. So this chart shows a medication called Indinovir, which it is a protease inhibitor, and it's not much used nowadays. And if you are using it, I would tell you to consult with maybe an HIV provider, or if you see a patient on it, because this isn't something we commonly see. And so what we end up seeing in the presence of Indinovir is that there's a 92% reduction of this medication, where rifapentine is right in the middle, about 70%, but rifabutin we see only about a 34% reduction. So we probably could use that being the safer option, rifabutin, compared to rifampin. In terms of changing AUC with those inhibitors, we see rifabutin causing an almost 300% increase. So with that being said, that's something that it would be a major drug interaction. And so we'd want to potentially use other medications, because then we would start to see those toxicities that would be increased. So I think, seeing that these do have their differences, there are certain indications of when and how to use these medications. So when we go back to what medications that we want to initiate therapy for this patient, we do have a couple of options. Yes, we could potentially use as an alternative Isoniazid, for 6 to 9 months, and that would be with pyridoxine. But we would really want to try to get somebody on a 12-week course of therapy. And again, we would have to have close monitoring of the patient. So the patient couldn't just, come back 12 weeks later and be like, okay, I'm fine. From this standpoint, we would want to make sure that we're monitoring their blood pressure, make sure that they do have a blood pressure cuff at home, make sure that we're having them come back. We just don't want them to, go and beyond this treatment. The other thing that I do tend to see if we're using our pyridoxine, when I put a prescription in for this, I put that it should be dispensed with pyridoxine, especially obviously the INH, because a lot of times it is over the counter. And so our patients, it doesn't go through the insurance, and maybe our pharmacy doesn't tell them that they need to get it. So I say that it has to be given with pyridoxine because we want to prevent any toxicities with INH from that regard. So that's one of the things that I tend to think about.
So Melissa, this is something I actually get called on quite a lot is the patients taking 3-HP and their rifampin is only once weekly, they'll call me and ask me what to do about drug interactions. And, of course I'll say, well, I need to look these up because like you, I can't remember all of them, but it's when a medication is being given every single day, it's a little easier to predict what the impact is going to be. And you may know more than I do, but I think outside of some of the HIV drug interactions, there hasn't been a lot of research to help guide what do we do in patients who are taking once weekly rifampin. What are your thoughts on that?
Yeah, I think that's, it can't be, it's just, HIV meds or, we think of seizure medications, we think of warfarin. We can monitor those. Again, it's really going to be about monitoring. We think about other, maybe if it's an antidepressant medication, we want to make sure that we're, monitoring the effects. We're checking in with the patient. With the nice thing, again, we go back to, how we're doing these webinars. We could do telehealth visits just to check in on a patient. It doesn't necessarily be that we have it where it's video, but we could call a patient. Again, it's that constant communication, making sure that the patient is doing okay. Maybe in the idea of if they have depression, making sure that their depression isn't worsening. Right. Again, this is 12 weeks of therapy. It's a finite period of time. So I think, making sure that a patient is aware of that, that tends to help them get through it as well. They know that they're not going to be on it for the rest of their lives per se.
Right. And certainly the data stands that out, that these shorter rifampin-based regimens are have much higher treatment completion rates. And just as a clinician, what I tell people is exactly what you said. It kind of depends on what the issue is. If it's a patient on Coumadin who's going to be taking 3-HP, then I might measure their INR more frequently during the treatment with 3-HP if that ends up being the regimen that we choose. And that it's kind of the issue of the one day where it's the most in their system, do they need to, is there any kind of risk there? Maybe that patient needs to have rifabutin every day so there's a steady state and you can measure it during the period, or maybe they just need to be on INH. But the other thing, if it's something like depression or blood pressure or cholesterol medicines that are interacting, I'll assess that particular patient. If they're like mildly hypertensive with no end organ damage, I'm not going to worry about them being that out of whack with their blood pressure being a little bit high throughout the 12 weeks, but I would encourage them to get their blood pressure monitored more closely, and I would communicate with their doctor just to make sure I knew that, that it was mild and indeed there wasn't a concern with your patient that you're presenting here. Pre-transplant, really severe hypertensive, this patient could have, really significant outcome if their blood pressure gets out of control and becomes too high. They could stroke, they could have, more damage to another organ. And so that's a patient where I might say, it does matter. I need to be a lot more careful about an interaction in this patient, and kind of depression might be, again, an example where, I'm going to find out, has this patient been actively suicidal? Has this patient had really significant issues where having their psychiatric drugs get subtherapeutic could have a really bad outcome. And so, there's not a one size fits all answer to which treatment you pick. You really have to look at that individual patient, the medications they're on, and what the potential consequences are, and then discuss it again with the pharmacist preferably, but many in public health don't have that wonderful opportunity. And so then discuss it with their primary provider or whoever else is managing their medications. And I'm going to hold questions till the end, but I do see this question about monitoring. And since we are saying that a lot, I think that we always are talking about clinical monitoring because that is recommended at every dose of any medication. When you're giving it to them, how are you doing? Are you having new side effects? Are you having new problems? Are you able to tolerate this? But if you're talking about meds that might affect their liver, you would want to increase your monitoring, depending on what that clinical scenario is for that, that patient and that drug. Any other comments on monitoring and what you mean by that when we are talking about it?
Absolutely. So the other thing I think about a lot is I actually will take the time to sit and talk with our patients about what we may see. I tell them that it's a potential and it doesn't necessarily mean that it will happen to them, but I want you to let us know if you start to experience any of these effects, X effects. And so that will cause the patient to reach back out to us and say, hey, I'm having this side effect. Maybe I need to, then I'll say, yes, we need to monitor more closely. And I think of this one patient that I had, I don't know, my gut feeling told me that they were going to have isoniazid issues with liver function abnormalities. And so, it was him, his wife, and his daughter wasn't there, but I emailed her just to say, hey, if your dad has any issues where maybe he has anorexia, he has abdominal pain, maybe he feels more fatigued, I want you to let us know. And inevitably, it was like Friday at 5 o'clock, I get this email and saying, my dad isn't eating as much. He's feeling way more lethargic. And, he is saying that he's having some GI pain. So we ended up getting him into the lab urgently. We were able to make sure that we got him an appointment. And sure enough, his LFTs were on the rise. He had been on therapy maybe for a week at this point. And so what we ended up doing is monitoring him, and his LFTs did normalize after another couple days of therapy. And they weren't super elevated. They were less than 3 times the upper limit of normal. And that's kind of like my threshold for somebody who is symptomatic. So we did monitor them a lot more closely. But again, I think if you're telling a patient as to why they need to be monitored closely, it's their health. They're going to want to make sure that they come in a little bit more so, especially when you talk about warfarin. If some of our medications reduce how well warfarin works, they could be at risk for a thromboembolic event. If they're having, maybe shortness of breath, maybe there's a pulmonary embolism, then they usually will tend to let us know and understand why they need to come in a little bit more frequently. I understand it isn't really great to have to come to a provider's office more frequently, but during this time, I want them to know what they may see, and that will trigger them to reach out to us.
Yeah, and I think prevention is the key. So in that situation, more monitoring with the INR would be essential. Well, let's move on because, gosh, we are just talking and covering so much ground, but we still have lots to go. So
absolutely.
I'm going to let you go on. Thank you, Melissa.
Absolutely. As you can see, I'm very excited about this topic. So we have our next patient who has HIV and latent TB infection, and she's newly diagnosed with HIV, but she actually requested to be seen by a follow-up for a provider, and I'm glad she did in ID. So it was one of our interdisciplinary patients. They were started on antiretroviral therapy and latent TB infection therapy about 2 weeks ago. Her past medical history is there for you. And most importantly, looking at their medications. So she's on bictegravir, tenofovir, alafenamide, and emtricitabine, also on antidepressant, on oral contraception, and then our isoniazid, rifampin, and pyridoxine. So our provider didn't necessarily, not in ID, but elsewhere, didn't check for drug-drug interactions. So we'll see how that kind of comes into play a little bit later. But she has a good CD4 count. She has a viral load that is a little bit detectable, but that's to be expected. She just started therapy. It did go down. So we're all, in the right range of things. Her AST, ALT is normal, and so is her kidney function, and chest x-ray is negative. So what do we want to have for our patient? What are we going to do here? So I'm not sure if all of you are aware of this interaction checker, but it comes from the University of Liverpool. And this is one of my go-to resources. It's free. It's available to everyone. And I like to be able to have a visual representation of some of these drug-drug interactions that I may see with our antiretroviral therapy, as well as a whole host of other medications. The other nice thing I will also say is that this isn't just for HIV interactions. You can go through the University of Liverpool. They have medications for oncology, for hepatitis C, even for COVID. So you can look at drug-drug interactions, but this is a really great resource if you haven't used it in the past. And so in the essence of time, I put in a lot of these drug-drug interactions for you. And so what I end up seeing from here is that we have rifabutin, rifampin, and rifapentine. And so the circles that are in red means don't do it. Or, we have to make sure that we're not effectively doing this without monitoring. But the other thing is that these are all the single tablet regimens. The only reason I chose these is because that's what all of our patients want to be on. They want to be on a one pill once a day if possible. And so with our commercially available, a lot of our first line options, we do see some integrase inhibitors. So bictegravir would be a contraindication. But I see that I might be able to get away with using dolutegravir-based therapy. Again, I look at then elvitegravir with cobicistat, which some of our patients may be on. And I see that rifampin or rifapentine maybe is not ideal. But what I do see is that maybe I can use rifabutin. So there are some options that I do have here. With tenofovir, TDF is one that I can use. So a lot of our patients will tell them, hey, maybe we could use tenofovir disoproxil fumarate, the older formation of tenofovir. And with a lot of the media and attention that's been on it, a lot of our patients will tell us, no, I don't want to take this medication. So, it's something to think about, but really looking at these drug-drug interactions here. The other piece of it is that it is updated very regularly. So as you can see, cabotegravir has made its way in here, and that's our newest medication, the long-acting injectable. So we have some recommendations, and it definitely does show what can be used, the rating of if you can or cannot use these, and any data that is available here.
This is so great. I love this. And just to highlight again, this one is free. So
absolutely free. So that's the nice thing. When we look at dosing recommendations, again, I look through a couple of things. I go to there. I look at our guidelines, our national guidelines from DHHS, and I've provided you with a resource here. I won't go into every single drug interaction and what the recommendation is, but we do have potential options for when we're using rifampin. If I need to use this, I can use the integrase therapies of dolutegravir and raltegravir. I just have to increase the doses for these medications to twice daily. And again, our patients may not like the idea of being on a BID dose, but it's only for a certain time being. And the other important thing is that we cannot use, it's not been studied, for the high dose formulation of raltegravir to be used with rifampin here. So again, I think that's the take home, is just to use those BID dosing of the traditional the raltegravir. In terms of rifabutin, we see a lot of the drug interactions with those NNRTIs, with our Maraviroc, which is an entry inhibitor, as well as with protease inhibitors. And so what tends to happen is we may need to increase the dose of the NNRTIs. For Maraviroc, we would have to reduce the dose of Maraviroc here. Instead of 300 BID, we would go to 150 BID. We don't use this a lot. But then with protease inhibitors, we would want to reduce the dose of rifabutin to 150 milligrams every day. Back when I started training, we would do every other day rifabutin dosing. But again, I think if we're doing every other day, there's a risk for missing doses. So just that consistency is really important here. And then these are some of the combinations and contraindications to make sure that we do avoid. And so, I provided this as a resource for you. I don't necessarily need to go into every one of them. But what you'll see is TAF-based therapy is more of the contraindication. So that's really what our NRTI go-to is in a lot of instances. So we do have some alternatives that we could potentially use. The other thing I do want to bring your attention to is there's was data that came out in 2020 that looked at a phase 1 and 2 trial that was performed in South Africa in virologically suppressed individuals. And they were given weekly INH with rifampin, and it was with traditional dosing of efavirenz or dolutegravir. So once daily dolutegravir, which is the nice thing. And this was in 60 patients, and they found that this is something that could be used. So I don't need to necessarily increase to BID dosing of dolutegravir here. The one limitation is it wasn't studied in children, as well as it wasn't in antiretroviral naive. So this was after patients already had that viral load reduction and they were virologically suppressed. So I think more data is needed, especially in those two populations. So again, here are my two resources. I'm doing my due diligence. And so here's what we see is that we have a red do not co-administer with our rifampin and as well as our Biktarvy, our bictegravir-based therapy, but then also looking at the guidelines through our HIV guidelines, and we see that we shouldn't co-administer rifampin with TAF because it can reduce TAF-based dosing or the concentrations, but then also we see with bictegravir we should not co-administer. What I do see is that TDF-based therapy or even a Bacavir, as long as I get that HLA that's negative, I could administer this therapy. Also, I could use reltegravir for that BID dosing again. The other thing that I also think about is this individual is on oral contraception therapy. So again, we have drug-drug interaction here, and I do not want the patient's contraception to fail if that's what they're using it for. So we see that estrogen can decrease by more than 60%, and progestins can be reduced by about 50%. So I think really what we need to make sure that we're telling our patients is that we need to make sure that they are using non-hormonal contraception barriers for therapy.
Yeah, and my clinical tidbit is that some people may not come up with a conversation. They may not think of that as one of the medications they're taking. And so right after you warn them that rifamycins may affect, causing them to have orange or red discolored urine and tears and other body fluids, that's when you say, and if you are trying to avoid getting pregnant and you're taking any oral contraceptive medications or hormonal contraceptives, please use something else as a barrier precaution while you're on any of these medications. And also, for, as you mentioned, several weeks after the rifamycins have been stopped.
Absolutely. And that's what, I tend to, when we're looking at the assessment and plan for this patient, again, if I had been there initially for the discussion, we would have managed this differently. But this was one of our telehealth patients in the Department of Corrections. And so their just go-to is INH and rifampin for everyone. So I'm glad that the patient requested that they saw us in clinic. So again, making sure that we educate the patient. But then we needed to make sure that we changed the patient from TAF-based therapy to TDF-based therapy or a Bacavir as long as their HLA was negative. We could continue on the emtricitabine, so it would be coupled potentially, with TDF-based therapy, and changing bictegravir to reltegravir 400 BID until latent TB treatment was completed. But again, that is such an important point. Those 2 weeks from that induction period, we want to make sure after we discontinue therapy because there could still be the rifampin hanging on within the patient's body. So absolutely vital to make sure we include that. Now, there's a lot of buzz around 2 drug regimens. So instead of, single tablet regimens, now how can I reduce the number of the number of medications I'm taking? And so what I can say is that's something that has come up clinically in our practice. There's no data on this at this point. So I guess the one take-home message is making sure that if we can encourage using 3 drug regimens in that single tablet formation is the safest option. But again, this might be something that will be forthcoming in the future. So at this point, we don't have enough data to recommend 2 drug regimens for latent TB treatment, especially with rifamycins. And so the one resource that we have that is available and is updated every 6 months or so is by yours truly, Dr. Haley, where it is a TB and HIV co-infection card. And so this will help clinicians being able to manage not only TB therapy, but also latent TB infection.
And I'll just say that it says May 2016 because this is an old picture, but we do try to update it every 6 months. And I believe that we can put the link in the, oh, someone's already beat me to it. The pocket reference is right there in the chat. And it's also on this slide. And the new version will be coming out soon. And again, it's done as a combination of SNTC and our partner, the AETC. And we have Joanne Orrick is our I think her last name is now Urban, but she is our pharmacist in TB HIV, and so she helps us as well.
Thank you for that. All right, we're moving through this clinic rather quickly today, and so we have another patient who's a 44-year-old female, long-standing lupus and on immunosuppressive therapy, is having increasing pain, and there were new vertebral lesions on imaging in which she was referred to oncology. And at this point, her immunosuppression was held. Her past medical history is outlined. Notably, she's had osteoporosis with fractures, avascular necrosis, hypertension, antiphospholipid syndrome, where she's actually had status post DVT. And her medications are listed for you. So belimumab, I always get a tongue twister on that. Mycophenolate, warfarin, hydroxychloroquine. It's not used for COVID prevention. It's actually used for immunosuppression. And as we know, a year later, hydroxychloroquine is not going to prevent your COVID. We won't get into that for sake of time with this presentation. And then prednisone therapy for this patient. Now, she did have a positivity for tuberculosis. And so it was through the IR-guided biopsy where AFB stain was positive, but there was no mutations that were identified. So we have a lot to do here. We need to treat TB. We need to restart immunosuppression if possible and continue anticoagulation. So just a little bit for visual representation. I know we've gone through these, but for the metabolism of RIPE therapy, we see that there is a substrate, those inhibitors and inducers. And so there are a lot of things that we have to consider. And again, we have to look at renal versus biliary elimination for our patients, and then how long we're going to treat therapy. So I already know that we have, based off of initiating therapy with RIPE therapy, at least a 40% risk of drug-drug interactions based off of, what our previous data has shown us. But now when we add in our patients' other drug interactions or our other drugs, we know that there's up to an 80% risk of drug-drug interactions here. So what we see is that there is a contraindication per manufacturer, per the drug interaction checker with mycophenolate as well as rifamycins. But again, if we need to continue this on, we need to be monitoring levels. So maybe not necessarily an absolute contraindication, but if we do have therapy available to us where we can do drug concentrations, that's really what we would recommend here. So, sometimes those interactions will show up, but again, we would want to make sure that we're consulting with experts here. And if we need to send away for drug levels, this would be something we need to make sure that we're doing. Of course, warfarin, I feel, is kind of like rifamycin. It's going to interact with a lot of medications. So in this instance, rifamycin can reduce how well warfarin works. So again, we are going to make sure that we monitor INR much more closely, because the last thing is for a DVT or a patient to have a pulmonary embolism or something worse to happen. It will reduce how well the INR levels are achieved. We see prednisone, and that's not something that we always are thinking about. We'll talk about that in just the next slide. But that's something we definitely need to make sure that we're monitoring for how well this is working for a patient. And we see category B here for hydroxychloroquine with rifampin. There was one case report where a lupus flare did occur in just standard therapy for hydroxychloroquine with rifampin. And here it says that there's no action needed. But again, we're going to be monitoring. So there is the potential for interaction, but it's not something that we will commonly see. In the case report, it did, when hydroxychloroquine was increased to 400 milligrams once a day, the patient did just fine. So again, it's just about monitoring for these drug interactions. And again, it's not something that we can't continue using these drugs. So specifically, when we look at prednisone-based therapy, we can see that prednisone concentrations can be reduced in the presence of our inducers being a rifamycin. So what we need to think about is we may need to increase the dose of prednisone-based therapy here. So, in literature, there was evaluations of what to do, and you may see a 2 to 3-fold increase in dosing that's necessary. But of course, with more drug comes the risk for more side effects. So again, something that we need to make sure that we're going to be monitoring, because what we can potentially see is that there's going to be a reduction in the clearance of increase in the prednisone clearance that we see. So it could range from almost 40% to about 95%. So that's something we need to make sure that we're assessing for our patients. So, our patient was on 20 milligrams of prednisone at a minimum. We may need to see it go up even higher than that to 2-3-fold increase. So again, it's going to be very patient specific here. And so we have a long list for our assessment and plan. This note is going to take us a very long time to write, is what I think about here. So we're going to initiate our TB therapy, since it was drug susceptible, with our standard RIPE therapy. But what you will see here is rifampin is not going to be used. It would be rifabutin because it's going to have minimized drug-drug interactions. Of course, we're still going to be monitoring our patient. We're going to need to increase our dose of prednisone, as for those reasons I had mentioned. And then we're also going to have to make sure that we perform therapeutic drug monitoring where available for our rifabutin and mycophenolic acid, because again, we want to make sure that there's the balance of, reintroducing immunosuppression. And again, this is going to be used in conjunction with their other providers. We're not going to just do this alone. We're going to make sure that we have everybody, all players, aware and on board with what's going on. As I talked about, warfarin INR can be reduced. And so at some points, we may be increasing warfarin to a level that's no longer safe, or a dose that's no longer safe. So we may have to consider other options, specifically, which we can talk about in a little bit. And so we want to make sure that when, again, we discontinue that rifamycin, we wait the appropriate amount of time, because we don't want to wait and see where the patient's warfarin will increase and then put them at risk for bleeding. We'll restart their belimumab and then continue their hydroxychloroquine. So again, making sure that we're doing this in conjunction with everybody involved.
One comment that I'll make, it's certainly important in patients who are immunosuppressed when they're coming in, or that, we are careful about the drug interactions, but I also want to remind individuals that sometimes we use prednisone in patients for TB meningitis, for iris, and And I see this all the time. Patients are given a small dose of steroids for a short period of time, and it's just not adequate when you throw in the interaction with the rifamycins. And so don't be shy about the amount of steroids you use, particularly if you have a patient with CNS TB or TB meningitis, where the downside would be the increased inflammation and prolonged neurologic disorder or dysfunction or death. So don't be shy and know that you have to increase the steroids, from the beginning, because they're also on the rifamycin. So with that, I'm going to let you finish. But Melissa, we're getting a little tight on time. So maybe we can go through the rest without just a little bit quicker. Thank you.
Okay. And we're here with the audience response question in terms of anticoagulant, which is the safest to use with a rifamycin. And so there's apixaban, dabigatran, enoxaparin, and warfarin.
Well, they are hard at work giving their answers. You've got about 15% who have responded. They're still going at it. 50% are saying Levenix.
Great.
Yeah, Melissa, why don't you go ahead and give the answer just so we can move on?
Yeah, it's going to be Lovenox or enoxaparin. That is going to be the safest to use. Minimal drug interactions, but that's something for the DOACs specifically, the apixaban, dabigatran. There's not FDA validated monitoring available yet. We can still monitor for enoxaparin, and then as we had mentioned with warfarin, we're able to monitor. So I do want to make sure, in the interest of time, that we're able to move on, and I seem to have been stuck here. Oh, there we go. So let's talk about very briefly multi-drug resistant TB. The recommendations were updated in September 2019. But really the major thing is that we do have the potential for an all oral option, which is nice compared to previously. So what we think about for multi-drug resistant TB is going to be really individualized therapy. We want to make sure that we use 5 or more drugs that are susceptible, and really importantly is going to be in consult with one of those centers for excellence. We want to make sure that we have a medical consultation on board because these can get to be pretty tricky cases. So I won't go into all of the drug treatment. It is outlined here. But I do want to make sure that we do have time to go over our drug interactions. And we see that, when I see a CYP inhibitor, inducer, bedaquiline is going to be notorious for having some of these interactions, as well as pretomanid. It does say to avoid where possible, but again, it's really going to be prioritizing in this instance the TB medications. We also have to be concerned with QTC prolonging agents. So aside from bedaquiline, clofazimine is going to be another medication. Our quinolones are notorious for this. So again, monitoring. That is going to be the most important aspect of it. And then we also have linaselid. So that's really going to be with that serotonergic component of it. So we'll talk about this in a little bit more detail here. Again, prioritizing our TB medications. So when we look at bedaquiline, we want to see, we see that rifamycins or any other drugs that are going to induce or suppress 3A4, we want to monitor the serum drug concentrations to ensure that we're minimizing the risk for resistance. We also need to make sure that we're monitoring for QT prolongation, and that's going to be at the beginning of therapy and throughout treatment as well. And so, various medications that can cause it, amiodarone, we see some of the antipsychotics that can cause it, antidepressants, but we want to be able to monitor these EKGs or ECGs. And so there are various apps that are available. Even your Apple Watch can monitor for QT prolongation. But so that's something just to make sure that we do have available for our patients. And it is recommended that if it is over 500 per the package insert that we, think of alternative therapies, because this could be a fatal potential adverse effect here. So when we think also about Linaselid and SSRIs, we also think that Linaselid is a weak inhibitor of MAOIs. So we see that we have to, make sure that we're monitoring, as we talked about earlier. And with serotonergic syndrome, this less than 5% that it occurs in, so it can be very early on in treatment, or it can end up being greater than 6 weeks after therapy. We just want to make sure that the patients are aware of potential effects and monitoring. And we can do therapeutic drug monitoring of Linaselid, where our goals would be for less than 2 microgram per ml, and Linaselid peaks between 12 and 26 micrograms per ml. And this has been validated, and it's been published so that you can use these goals, and they're highly recommended.
In terms of make that comment that this is our standard practice at the SNTC and I believe elsewhere. And so we have found some funding that we can assist other programs with using drug monitoring for Linaselid in particular, because the toxicity can be substantial if the drug levels, if you don't monitor, and the so keeping that trough less than 2 is the key. And just reach out to SNTC if you feel that you need drug levels and your program is not able to provide that to help your patient.
Great, thank you for that. Our last audience response, so what herbal supplements or over-the-counter medications should be avoided in patients taking TB therapy? And I'm pretty sure I kind of gave that test-taking tip out earlier, so I'm sure everybody will make sure that they answer it.
Why don't you just go ahead?
In the interest of time, it is going to be all of the above. We see aluminum hydroxide with ethambutol, so we need to make sure that we're separating it. St. John's wort, it interacts with everything. So if you see that again, we may not see it in all of the literature, but that's because it's not been studied as extensively, but there are tons of studies looking at it. So even if it doesn't maybe show up on a drug interaction checker, it's something that does make me very concerned. And with acetaminophen, again, with isoniazid or even any hepatotoxicity is something we think about. All right, so we're in the home stretch here. We only have a few more slides to get through. And so I do want to bring this up because there was a Dear Colleague letter. There was a lot of information that kind of came out in the summer of 2020 where there were the potential for nitrosamines to be identified in rifamycin, specifically rifampin and rifapentine. And so this is something new that the FDA is starting to monitor a little bit more closely. I'm sure you heard a lot about this with some of the antacids that are available, with some hypertensive medications. But specifically, the drug company who makes rifampin, rifapentine, voluntarily withdrew 3 of the rifampin-based medications, as well as reduced shipments or halted shipments of rifapentine-based therapy because of a known nitrosamine that was in rifapentine, an impurity. And so they're doing more studies on this, making sure that there isn't any carcinogens and making sure that they're at an acceptable level. And so there is no current shortage of rifampin, but there is a shortage of rifapentine at this point. We tried to use it recently. We were unable to get it. So I think my take-home message is, if you have access to it and you're completing somebody's therapy, they should be prioritized for treatment. And if not, don't start somebody on it and use alternatives. These are some of our practice improvements of what we basically talked about throughout this talk. So I want to make sure that maybe basically for me, making sure you ask somebody at every visit, even including DOT visits, of what medications they're on. Have they changed? Are they over the counter? And again, ensuring that a patient is able to access all of their medications. Like I said, when I put a prescription in, I call the pharmacy to make sure that they're able to get it. see if there's any co-pays. If you're going through a Department of Health, there's a lot of resources that are available there. Pairing with a center of excellence is going to be paramount in ensuring that all patients do have access to therapy. Here are your available resources of who you can contact, which is color-coded based off of region. And when there's no pharmacist around, there are resources. There are various free ones that we've talked about. And then there's fee-based ones that a lot of institutions do have available. When you're looking for drug monitoring, there are 2 sites that do a lot of the TB drug monitoring. And so just for you to be able to have these resources, and here are some additional resources for you to use in your practice. With that, I think we went through a ton of information, and I'm happy to open it up for any questions you all may have in the time we have.
Melissa, that was absolutely fantastic. I just think that was one of my favorites of the series that we've done, and just as good this time as the first time I heard it. There are some questions. I do want to let the audience know that if you need to go, we will have this recorded and you can listen to it again at your convenience. And we would love for you to continue to join us through our odyssey of these different When TB is the Least of Your Worries webinars, and just also that we are working on some online modules to go with these so that you can come back later and listen to the webinar, answer some questions, and maybe even go a little deeper so that you can get CEUs, CME, and we may ultimately end up trying to get credit for pharmacists too, especially for this one, Melissa.
Great.
Connie, if I can just hop in here real quick, I know people will need to leave. Remember to do your evaluations. Those should come to your email, but in the next 24 hours. If you joined by telephone today, I have no way of knowing who you are to connect you to an evaluation. So please email me. You can go back to your confirmation email for this event and email me and give me your phone number and your email address, and I will make sure you get connected. And with that, I'll turn it over to Connie. If you need to leave, we understand. If you can stay, please do.
Thank you. Well, we've got some questions, which I'm excited about. Melissa, I might take the first one, but I would definitely love your input too, because this is a clinical call that we get quite a lot. So the question from Julie Rose was, in a patient with disseminated TB disease, would you withhold immunosuppressants during the intensive phase? And what I want to say is absolutely not. Think about our patients who come to you immunosuppressed, such as HIV. We can cure them of TB no matter how low their immunosuppression is. The problem that we see is patients who, I see this a lot, patients come in, the physicians in the hospital or elsewhere may be concerned that their immunosuppression caused the TB and they therefore need to hold it. And what happens is they end up having a really significant immune reconstitution. And so what happens is that they actually can be getting better and then they get clinically a lot worse. And we even have had, in fact, our lupus patient that we presented in this case was exactly that. She came already on TB treatment and her immunosuppression had been held. And so she had developed a really intense paraspinal abscesses, lots of fluid collections up and down her spine, and a lot more bony destruction. And our approach was to certainly check the drug levels and make sure she was getting enough TB therapy to make sure that the patient had not developed any resistance and make sure the patient was adherent to treatment. But we restarted her treatment with steroids and the mycophenolate, and her fluid collections absolutely dissolved and she got better. And so that is just a great question, but I do see that a lot. So you want to comment on that, and then I'll ask you some of these other questions?
Yeah, no, I think what you had touched upon, that is absolutely spot on. So I do not have anything to add to that.
Well, good. Okay, so Keith Everett asked this question: what is 6 to 10 alcoholic drinks a day due to my treatment? And I think he's talking about the treatment he's giving to the patient, but no judgment there.
I mean, that's what I'm going to have after this talk now.
Right, that's right. This was a big lift for you.
Yeah, no, obviously it's going to impact potentially the liver function. So if it's every day, if it's constant, absolutely, we need to be monitoring liver function testing. But again, it's not something we would recommend even if you weren't on TB treatment, I guess, or latent TB therapy. But we do realize that people, do have alcohol with it. Again, alcohol is going to potentially raise your LFTs, especially in conjunction with therapy.
Does it also have some effect on the cytochrome P450? Does it act somewhat as an inducer? I feel like that's somewhere in my brain.
Yeah, it can potentially do that. But again, it's more going to be with a concomitant raising the hepatotoxic effects.
Mm-hmm. Okay, great. And we were focusing, in a broad picture, but we weren't talking specifically about adults versus children. So are these interactions that we were talking about the same for children and adults, especially when we're talking about active TB disease?
Yeah, they would be the same that we would see again with certain medications. We would have to go up on dosing, but again, we would be seeing these in children. Again, some of our disease states for children would have, obviously different medications that they may see, but this would all be very similar in that regard. Absolutely.
We do therapeutic drug monitoring on children as well, especially when you have children that have severe forms of TB, like, again, CNS TB, TB meningitis. And it helps to know that they're getting the right drug because, they can't always tell you how they're feeling. They can't always describe whether they're getting better or not. And so, especially in infants and young children, it may be hard to assess them clinically. So please keep in mind, we're glad to do that for you. And sometimes we'll also not just do the TB meds, but we'll do HIV meds, transplant meds. And if there's something else that a child is required, seizure meds, most of those you can get from a commercial lab, but we're glad to try to get levels on important drugs that a child needs to have to ensure that they have good outcomes from the TB treatment. One other question, Charles Callum has put in a question about contraindications to using Lovenox as therapeutic anticoagulation throughout the full course of TB therapy. Actually, I think that might have been Ed Kahn.
Yep, I see that there. We don't have any contraindication per se to using it because it doesn't show a drug-drug interaction necessarily. But again, we would be wanting to monitor levels for our patient. I think it goes back to all that monitoring perspective of it, especially if they maybe were on warfarin and they were at elevated doses and not achieving their therapeutic effect. Again, we want to make sure we prevent any future VTEs in these patients.
Yeah, a lot of our patients with TB, we're seeing a lot of similarities to COVID, that the inflammatory response to TB, including the effect on hypercoagulability with TB, is really something that we see quite a lot. And it's not that uncommon. I can't remember the exact percentage, like 10 to 15% of TB patients may have, subclinical or even clinical, pulmonary emboli and other things like that. And so it is important to make sure their anticoagulation is adequate. And as you mentioned, Lovenox is our go-to, and it is sort of a standard dose, and we can get factor 10A levels. But for the direct acting anticoagulants, this is something where we're really hoping to be able to move to that in the future. But the issue is, again, right now they're used sort of as a one size fits all, and that's really not sufficient. We want to be able to measure, if we can measure, is it anti-factor 10A that we need to measure to make sure that they're having adequate anticoagulation. And so I think that'll come. It's not there now.
Stay tuned.
This is the first time that TB, there's so much new in decades. We have new diagnostics with molecular treatment. We've got new, regimens for NGRTB. We're looking at potentially having shorter regimens for TB treatment, and certainly the LTBI, short course therapy, is so exciting. And I just think, again, people realizing that we need to find ways to manage their other conditions while we're treating TB, and finding out how to manage these drug interactions, hopefully will be part of the future. Somebody asked about 3HP for children as window therapy while awaiting the second round testing. And I think, what are your thoughts on that?
Yeah, I mean, so with our 3HP, we have, I go back to the slide that we had put up with the CDC. All right. Oh, I don't have my screen sharing. And so, we think about that is something that potentially could be used. I don't see why not. But again, it's going to be coming back to what we have available. And right now we're not really able, at least over here, I don't have access to it. So maybe Department of Health would have it because we're still having a shortage that from our standpoint.
Yeah. So we are, it's about 1:36. I'm going to ask you one last question and then let's close it out. And I apologize if we didn't get to all the questions. We'll try to answer you offline. But there's a question on oral contraceptive failure rates with rifamycin co-administration. I do want to answer that because I think that, or would like you to, because I think this is such an important issue. I mean, I had one patient taking 3-HP that I was aware of that got pregnant. She was very unhappy. So what do you know about the rates of
I don't have the rate off the top of my head, but I know that this is something that we stress over and over again because you see the data before you, 50 to 60% reduction. So I guess probably it's lower, in terms of it would be lower than we would actually know because we're preventing it by using a backup method with non-hormonal contraception. We've had patients who, for religious reasons, don't necessarily want to use any backup method or any birth control options. So again, that's something we talk to our patients about. Again, it's all about using backup methods with that. So hopefully it is lower. There's not great data on it because we are preventing it if it is unwanted.
It is pretty significant interaction between rifampin, in particular, daily rifampin with the oral contraceptives because, they're steroid based. So, it's not occasional. I would say it's a significant issue.
Yeah, absolutely.
Well, thanks to everyone. I really hope that this met your clinical needs and will help you to better prepare and manage your patients. Really appreciate your support of the SNTC. And Melissa, I just cannot thank you enough. This was lots of fun to do with you. And I think that we'll hopefully have a resource out there online, this recorded presentation and maybe a interactive module as well. And so just great presentation, great expertise. And we're so glad to have you.
Thank you so much. And thank you all again for taking time out of your day to spend it with me. Have a great day.